So good morning, everyone, and let's get started. I think we have starting 5 minutes delay. Uh, we are having a session on eye health in elderly populations. Just want to check that everybody is in the right hall. So me, I'm Dr. Srinivas Marmamula. Along with me is Preeti and Chingi. So we will be moderating this session. So we have 5 speakers this morning. Preeti?
Hi. Yes. So welcome everyone. Are we starting?
Yes.
Okay. Welcome everyone to this. Hello. Hi. Okay. So a warm welcome to everyone here in this session. And okay, so maybe we can start the session. And our first speaker is Dr. Sahil. He's from Singapore Eye Research Institute. He has been working in Singapore epidemiology of eye disease study for several years now, and his talk today is on optimizing epidemiological study design for elderly, lessons from Singapore epidemiology of eye disease, or in short, SEED study in Singapore. Dr. Sahil, please.
Okay, good morning, everyone. Okay, the slides are here. Thank you for being here on a morning, listening to something which some people may think is boring, but again, epidemiological studies are the bedrock on which all the policy guidelines are made, so they are very, very important, and one such study is SEED, and I'll be presenting some interesting lessons that I have learned from this study. Thank you again for the session chairs to have me here, to APAO and to AIOS. It's always good to come back home to Delhi. So right now, I am the head of medical affairs at Medivale Inc. So these are the conflict of interest statement that I have. They are none related to this presentation. However, I have done some activities for these companies in the past. Going on, first and foremost, I would like to thank these world-renowned epidemiologists, Prof. Wong, Prof. Cheng, Prof. Charu, and Dr. Tham, who are critical parts of the SEED study. And I have learned from them, and some of the things that you'll see here are pearls of wisdom that they have shared over time. But yeah, nothing can start without my gratitude to these people. So the SEED study was established as a one-stop data portal. So this QR code will take you to the SEED study paper, which kind of describes the study in a lot of detail, gives you detail about what are the kind of tests that we have done in the SEED study, and what are some of the protocols and standardized methods that we have used in the study. The critical part was Singapore is a unique population, so we are able to cover the large 3 ethnic groups, which are the Chinese, Malay, and Indians. And all of them are being studied at the same time from the same location, so it can give you a very good baseline understanding of the diseases that happen in these ethnic groups. So this is the cohort profile paper that I was talking about. So this was led by Shivani and Dr. Tham. And if anyone is interested, they can go back and look at this paper for the details of the study. So the sampling has been done from Singapore. So these are 16 districts in Singapore. These are the most densely populated parts of Singapore, and it kind of adequately covers the 3 major ethnic groups. So this was how the study was organized. So it started in 2004 with the Malay population first, followed by the Indian and Chinese population. Right now, the 6-year follow-up has been completed, and the 12-year follow-up is ongoing. So we'll be completing the 12-year follow-up later at the end of this year. So one critical part about any epidemiological study is the response rate. So for the SEED study, it is about 78.8%. When we compare it to benchmarks like the Chennai glaucoma study or the LALE study, which is the Latino eye study in the US, you can see that the response rate is quite good. It's important to understand that these people have grown over this time and they are becoming aged. So maintaining response rates in the high 70s is very, very difficult. And I'll kind of come to some of the points that you can integrate in your study design if you want to have a good response rate for your epidemiological study. So this is the study design. The patient comes in, they undergo the demographics, and then it's a very standard examination set that happens for everyone, which includes the posterior segment imaging, and finally they are given a discharge report. So the impact of this SEED study is like this. So this is a screenshot from PubMed. There are about 2,418 studies that mention SEED. And this includes all the major studies that have come out from the Global Burden of Diseases, the IAPB studies, the WHO estimates on different diseases, and also the Ministry of Health guidelines, and also now the AEEC, which is the Asian Epidemiology Eye Consortium studies. So I've divided the lessons to learn into 3 parts, which are the procedural, administrative, and impact-based. So we'll quickly go through all of these. So standardization is key for any study. So important part is to have uniform protocols. This reduces the variability. Integration of electronic data capture is key because it reduces the error that happens when you are transcribing results. And it's very important to have good staff training. So that means that you should have standard operating protocols for everything. In the SEED study, we actually also have a standardized discharge material. So this includes the study documentation form, the information brochures which are given to the patients depending upon which disease they have, the reports, which includes the visual fields, the OCTs, and also the biochemical test results, and finally a referral slip in case we find something which needs an urgent intervention. Elderly safety is paramount because these are elderly people. It's important that you make sure the environment is safe for them. So that includes installing handrails, proper lighting, non-slip flooring, making sure your staff is trained to assist elderly participants for mobility support. And the important component is to have a fall risk screening. I'll show you how we implement this in SEED. So this is how we implement this in SEED. So anyone we feel has a fall risk, get these stickers attached onto their files, also onto their chests when they come into the study. So anyone who is a SEED team personnel can identify who are the people who need extra care while they are coming in for the examination. Going in, you can see from this image that we have quite spacious clinics. There is adequate lighting. We make sure there is enough spacing for the people to sit down. Whichever eye is being dilated, we put in stickers for that as well to make sure that everything is standardized. And for the toilets, we make sure that there is no risk of fall there. So you can see the handrails are attached there as well. Resource optimization is key for a large epidemiological study. That means elderly specific communication is very important. So they need to know how to talk to the elderly patients. All the diagnostic equipment has large size fonts, which are easy to read for the elderly people, and on-site support is there in case of any adverse event. Engagement is also key. So we try to do this by making sure that everything is personalized. So as you saw, there are 3 different ethnic groups. So we have people who can converse in 3 different languages as well. In addition, we also need to address the cognitive decline issue. And with cognitive decline issues, there is always chance that the reminders may be missed. So it's important to take the family members on board as well. So in this case, we have the Health Buddy app in Singapore. So you guys can see here, this app basically can be opened by the person who is the caregiver. And the messages are sent out to kind of make sure that the visits which are scheduled, they are compliant with the visits. And we also give them the referral forms, as I previously mentioned, in case anything is flagged off. And these metrics are also tracked to see how many of them actually go and attend a referral. For logistics, it's very important, these are elderly people again, that transport assistance is there. Home-based assessments can also be done, and it's always important to have easy accessibility. So like elevators, ramps, and adequate seating areas. So I'll show you some very interesting images here. So these are images from Singapore again. So these are the buses that bring them from the MRT. Again, you can see the handrails which are there to make sure that the elderly are supported while they are getting on and off the buses so that no one has a fall. Then Profong here you can see with the Vision Save bus. This is again a community-based initiative in which we actually take the clinic to the patient. So in this case, you can see the old lady is coming up to the bus. Again, the critical part is the handrails, making sure they have support. Then we have a OCT machine inside and also slit lamps along with the eye charts to make sure that we can do the examination there and then. If anyone is interested, they can have a look at the QR code. This has a video of how this is done in the community. Sustainability is key. Again, nothing like this can sustain if there is no funding. So for this, Prof. Cheng, Prof. Charu, Dr. Tham, all of them have been supported by the NMRC, the Ministry of Health in Singapore. And funding is what keeps something like this alive. But it's important that whenever you are trying to write a grant application, make sure you focus on the public health impact of your study. And that's more likely to then fund your study as well. Finally, we come to the outcomes. So these are impact-based outcomes. It's very important that the outcomes are not just numbers, but they are also real-life outcomes in this case. And the real-life outcomes essentially come from questionnaires. So in this case, SEED has a lot of questionnaires, and this is the metric which questionnaires are essentially always done. So you can see the VF14 is one thing that we have across all our cohorts. And here you can see the PHQ team, which is the public health team which we have. And we have developed some new questionnaires, and we also have then validated these questionnaires in our cohorts. And Dr. Preeti is also here, you can see her in the image. Going on, it's important that you have collaborations with top researchers to increase the study credibility and the findings that you have. And in this case, SEED has been always amazing. So you can see some of the citations here for individual papers are actually more than some people have in their lifetime. So again, these are major studies which have had significant impact on how diseases are managed and how funding is given for the diseases. We also make sure that when you are going out to a publication, if you have an interesting image, try to get it on the cover of these journals. And we have significantly impacted, say for example, with the publications like the Cell Journal, which has an impact factor of over 100. And this was the gene sequencing study which was featured on the publication cover. Going on, as I mentioned, collaborations are key. It's important to collaborate with different studies. For this case, there are a lot of new registries like the IRIS registry and TRUST, which you can collaborate with. In this case, also for Asia, we have the Asian Eye Epidemiology Consortium. So 10 countries are there in this, 40 plus epidemiological studies, and you can get access to other countries' population for validation of your own, for example, a deep learning model that you have. And this is Prof. Cheng, and he has been very active in establishing this, and we have written quite a lot of papers with the AEEC. Anyone who is interested, do reach out to me or Prof. Cheng to join this consortium. Finally, I'll just end with these key takeaways. Standardization in a large epidemiological study is vital, and it ensures that there is study integrity and those results are trusted when you publish them. Important thing is, because these are elderly, their safety should be paramount while you are doing the study. Resource optimization is key, because again, if you waste resources, you may run out of funding. Finally, it's important to make sure that there is sustainability in what you do, and sustainability can only come if you are able to network properly and then drive from those networks the results that you get for a significant impact. So thank you so much, and I'll take any questions if they are. So acknowledgements to the SEED team, and if anyone wants to reach out, yeah, definitely do.
So we'll have questions in the end because there could be some common questions. Sure. Thank you, Sahil. It's a very good presentation, and you've given the insights of what goes into conducting a successful longitudinal study. Often we report methods, but we really don't report some of the intricacies that are involved in undertaking high quality longitudinal studies. So we now have Dr. Preeti Gupta is going to present on low prevalence but high impact of uncorrected refractive errors in community-based older individuals, a population-based study.
Yeah,
Dr. Preeti Gupta is a senior clinical research fellow in population health research at Singapore Eye Research Institute, and she has been doing a lot of work on elderly and elderly eye health in Singapore. She is also a co-investigator on one of the most famous studies called as Pioneer, where she's trying to understand elderly eye health and its implications on health and well-being of this elderly. Preeti.
Hi. A very good morning to everyone. So today I'll be sharing some of the findings on the low prevalence but high impact of undercorrected refractive error in community-based older adults from the Pioneer study. So Pioneer is a population-based study of multi-ethnic older Singaporeans, Chinese, Malays, and Indians across the island. Well, we know that by 2030, it is estimated that 1.5 billion people globally will be aged 60 years and above, and 60% of these will be living in Asia. As population ages, sensory impairment, especially visual impairment, is becoming more and more common, affecting almost 50% of older adults. And undercorrected refractive error is a major contributor to more severe visual impairment, responsible for almost half of the VI cases globally. Singapore has one of the fastest aging populations in the world, and it is expected that the proportion of individuals with VI or UCRE will rise significantly in the coming years. Well, with the recent shift in the definition of VI and blindness from best corrected to presenting distance VA, it highlights UCRE as a significant and separate concern. WHO's Vision 2020 initiative recognizes UCRE as a leading cause of preventable blindness and VI. Unfortunately, UCRE can be easily and cost-effectively corrected with glasses, making it a significant or critical entity for public health interventions. However, despite these concerns, most research on UCRE in Asia, including Singapore, has predominantly focused on younger middle-aged adults. Existing data are outdated by almost a decade now and are not representative of the country's population of community-dwelling older adults. For instance, the study, Singapore Epidemiology of Eye Disease, which Dr. Sahil has shown in the previous study, was done almost a decade ago with individuals with a mean age of 55 years, and they were mainly residing in the southwest of Singapore. There is currently lack of data on the relative contribution of the risk factors to UCRE pathogenesis, which is important given we have finite healthcare resources. Moreover, there's insufficient information on the clinical and patient-centered impact of UCRE, and to date, there is no data on the economic burden of UCRE. So given that the existing data may not reflect the current aging trends, it highlights the need to examine the contemporary trends, risk factors, contribution, and the impact of UCRE in older adults. So to bridge these gaps in knowledge, one of the aims of this study is to determine the overall age, gender, and ethnic stratified prevalence of UCRE in a population-based cohort of multi-ethnic Singaporeans from the Pioneer study. And we believe that UCRE rates will be lower than those reported in the current literature due to the contemporary nature of our data, and given that there has been increased awareness, access, and utilization to eye care services in Singapore in the recent years. Second, we aim to examine the contribution of the socio-demographic, clinical, and lifestyle risk factors of UCRE in the same population, and several factors will be independently associated and significantly contributing to UCRE. Our last aim was to study the impact of UCRE on patient-centered outcomes, including vision-related quality of life, functional disability, as well as health outcomes such as sarcopenia, frailty, falls, and its economic burden in the above sample. And for this, our hypothesis is that individuals with UCRE will experience notable reduction in these outcomes compared to those without UCRE. So the data for this study is taken from the Population Health and Age-Related Sensory Decline Study, or in short, PIONEER. This PIONEER study was conducted between December 2017 to 2022 with a baseline recruitment of 2643 participants. Vision was assessed using standard logMAR number chart at 4 meter. Visual impairment in our study was defined as a presenting distance VA of worse than 612. Subjective refraction was performed in order to gather the best corrected distance VA. And UCRE in our study was defined as an improvement of at least 0.2 logMAR, equivalent to 2 lines, in the best corrected distance VA compared with the presenting distance VA in the better eye of individuals with VI. We assessed several patient-centered outcomes, including functional status, vision-related quality of life, falls, depression, loneliness, as well as the cognitive status. In terms of health outcomes, we measured the participant walking speed. For 4 meter, the hand grip strength was assessed using dynamometer, and the muscle mass was objectively assessed using dual energy X-ray absorptiometry, or DEXA for short. So using these 3 basic parameters, we then defined sarcopenia and frailty according to the latest guidelines of these definition. So coming on to the statistical analysis for the AIM-1, which is the prevalence of UCRE, we standardize our prevalence to 2020 Singapore census. For the factors associated with UCRE, multivariable logistic regression models was performed, adjusting for the potential confounders. Importantly, we did dominance analysis in order to identify the individual contribution of the risk factors to the overall model. And lastly, for the patient-centered and health outcomes, multivariable linear or logistic regression analysis, depending on what the outcome variable was performed, and for the economic impact, two-part model was performed. So here's the result. Sorry, my bad. For this study, we had total of around 2,600 individuals, and only 224 participants had UCRE, giving the census-adjusted prevalence of around 8%, and the prevalence increased with increasing age, as you can see here, although the pre-trends were not significant. There was not much difference between the two genders, and neither was there difference across the three ethnic groups, although Indians and Malays had slightly higher prevalence compared to the Chinese. Here's the characteristics of our participants by the UCRE status. Overall, in the univariate analysis, there is not much difference across the two groups in terms of socio-demographic or systemic profile. However, individuals with UCRE, almost a quarter of them had low socioeconomic status, and more than 50% were not wearing glasses. So in the multivariable analysis, after adjusting for potential confounders, we found low socioeconomic status was associated with almost 3 times higher odds of UCRE, and increased spherical equivalent was also associated with higher likelihood of UCRE. So when we looked at the contribution of these individual risk factors, we found that the two largest contributors were increased spherical equivalent and low socioeconomic status, contributing somewhere between 23 to 40% of the variance in the total model. For the patient-centered outcomes, we found individuals with UCRE had several adverse patient-centered outcomes, including poor visual functioning, loneliness. They were almost 3 times higher. They had almost 3 times higher odds of staying alone, 2 times higher odds of having lower gait speed, 2.5 times higher likelihood of having sarcopenia, and 2 times more likelihood of being frail. So lastly, when we looked at some healthcare expenditure, so among those who spent on healthcare expenditure, individuals with UCRE had 2.3 times higher odds of cost expenditure compared to those without UCRE. Well, as you have seen that we found lower prevalence of UCRE in Pioneer at 8% compared to almost 20% in SEED. And there could be several reasons for this. Of course, the very obvious one is the older age of our participants, and hence they are more likely to seek eye care services and hence get better diagnosis and also uptake of the correction. And as mentioned before, there has been increased awareness and access to eye care in Singapore in the recent years, so this could have led to the lower prevalence in our study. In terms of the global prevalence of UCRE, there's a wide range, ranging between 6.3 to almost 40%, and there are several reasons for it, and one of the most important reason is the discrepancy in the threshold which is used to define UCRE. For instance, some studies has just used the improvement in 1 line or even 1 letter, which has actually overestimated the prevalence in these studies. Well, we found higher magnitude of refractive error as well as low socioeconomic status to be contributing to almost 60% or more of the total variance in the final model. And despite the low prevalence, there was substantial negative impact of UCRE on several patient-centered outcomes as shown in my previous slides, which are important for independent and successful aging of our growing seniors. UCRE was also associated with higher likelihood of sarcopenia frailty. We know that individuals with visual impairment actually develop fear of falls, depression, and hence they reduce their physical activity as well as caloric intake, and these two are the major determinant of sarcopenia. Therefore, it's conceivable that correcting UCRE or VI can actually or may reverse sarcopenia via the new sight-enabled ability to partake in better diet and physical activity. So overall, correcting UCRE is not just correcting their vision, but actually it can enhance the overall quality of life of our elderly, giving them the privilege to age independently and gracefully in their golden years. So some of the strength of this work include a large, well-characterized and geographically representative sample involving the 3 major ethnic groups in Asia. We objectively assess vision as well as systemic data, and there was comprehensive data on the range of risk factors, making our analysis robust. However, there are certain limitations. For instance, as you've seen that we had limited number of the cases of UCRE, so we couldn't really do the stratified analysis for severity of UCRE. The study design is cross-sectional at the moment, and hence causal inferences can't be drawn. Well, some take-home messages are that despite low prevalence, UCRE we had seen had significant adverse impact on higher healthcare costs in our older Asian adults, which highlights the need to implement more effective vision screening programs for elderly in order to prevent UCRE. And public health education on the necessity of regular eye examination as well as wearing appropriate glasses would be really critical. And lastly, if we can subsidize the cost of refractive correction, that could really help mitigate the adverse impact and economic burden of UCRE in at-risk population. So with this, I would like to acknowledge my team for this work, and thank you all for your attention, and we'll be happy to take any questions at the end of this session. Thanks. Okay, so our next speaker is Dr. Srinivas, and he will be speaking on epidemiology of vision loss in elderly in India. Dr. Srinivas, please.
Good morning, everyone. I have no conflict of interest to declare. Whenever we talk about epidemiology or epidemiological paradigm, we are essentially talking about four things. It's a definition, what is the condition that we are dealing with. Then we talk about the magnitude and distribution, that is the numbers, how many people are affected, and where are these people. Then we talk about the causes and risk factors, what are the possible reasons for this problem, and who is more likely to be affected by this. And then essentially we need to control. So what are the solutions that are available and what can we do to ensure that this problem doesn't remain as a public health challenge. So today we are going to use elderly eye health, vision loss in elderly population, and we'll use epidemiological paradigm to understand this condition. So one of the important questions that we need to understand is, why is eye health in elderly more important now than ever before? This is one question that is important. In such a big conference like APAO, we are having a separate session on elderly eye health that signifies the importance of this topic. If you look at India, India is witnessing a demographic shift in increasing proportion of elderly people. By 2050, it's estimated that every fifth individual would be 60 years and older. And at the same time, there are a lot of societal changes that are taking place. The traditional joint family system, where multiple generations used to stay together, is now giving rise to nuclear families, where we have only elderly people living with only spouse or living alone. And all these things are making elderly more vulnerable to vision loss and also to other health reasons. It is very well known that aging is a risk factor for vision loss. And fortunately, most of this vision loss is avoidable with cost-effective interventions. Last year, India surpassed China as one of the most, as the most populous nation. While we have something to celebrate about, it also brings up a lot of challenges that we need to address. And one of the questions is, are our health systems ready to take care of this increasing elderly populations? So elderly eye health is extremely important. Now we are having more and more evidence emerging that eye health impacts almost every domain of elderly health. Eye health also includes, impacts economic independence, quality of life, social and economic well-being, self-care, falls, improved access for NCDs, and many other factors. Again, as epidemiological paradigm, we always need to define what we are talking about. Distance vision impairment is defined as presenting visual acuity worse than 6/12 in the better eye. Older studies use 6/18 definition, but more recent definition is 6/12. Near vision impairment is defined as near vision worse than N8 or N6 at 40 centimeters. Whenever I mention avoidable vision loss, it means the vision loss that can be prevented, treated, or corrected. And elderly in our context includes individuals aged 60 years and older. Globally, 1.1 billion people live with vision loss. The prevalence varies significantly across the globe. However, the global prevalence is about 14%. That means out of every 100 people across the globe, 14% of them have visual impairment. But the good news is 90% of the vision loss is either preventable or treatable. So this is the global population. We have 7.8 billion people. 596 million people have vision loss for distance. 510 million people have vision loss for near. This brings us to a number of 1.1 billion people. That literally we are looking at 1 out of every 7 people having either distance or near vision impairment. And as expected, vision loss is more common in older age groups. The second epidemiological paradigm is the risk factors. Who is more likely to have vision impairment? The people in remote locations, women, older age groups, people with other disabilities, and people living in older, underdeveloped regions are more likely to have a vision loss. There are several factors. Some of them are can be modified, some of them cannot be modified. We call them as non-modifiable risk factors, and aging is one of the important risk factors. India, we have a population of about 1.4, 1.5 billion people. 137 million people have vision loss for distance, and almost a similar number for near. This brings us to a number of 275 million people with vision loss in India. If you look at the prevalence, like what does this data mean to us? The prevalence of total vision loss is about 23%. That means 1 out of every 4 Indians has either distance or near vision impairment, in simple words. The most recent data on visual impairment comes from the national survey that was done between 2015 and 2019. It included 31 districts from 24 states and has a large sample size of about 93,000 people. The prevalence of blindness was reduced by 47% when compared to the 2010 baseline. The blindness itself has come down to 0.36% from 1% in 2006 and 2007, and number of people suffering with blindness also decreased significantly. While this is a great news, and I think we are doing very well in terms of addressing the vision loss, but still it continues to be a public health challenge. In 50-year and older age group, about 27% of them have a distance vision impairment. If you also include now distance near vision impairment also, it becomes almost like 50%. And look at the causes of vision loss. Cataract and refractive errors are the major causes, and then we have cataract surgical complications and corneal opacities. Again, Telangana, the place where I come from, the state where I come from, we have done a lot of population-based studies in this region. The prevalence of vision loss in the state of Telangana was about 33%. And when we translate this into numbers, 1 million people have vision loss in Telangana, which is a big number considering the population of our state. Literally every third elderly had vision impairment for distance. If you look at the causes, again, refractive errors and cataract are the leading cause of vision loss. We also looked at the unilateral vision impairment because studies have indicated that even unilateral vision loss can lead to impact on the quality of life. Again, here also refractive error and the cataract are the leading causes, but we also see the emergence of corneal opacities as one of the leading causes of unilateral vision loss. About 35% of them had unilateral vision loss. Putting these things together, 2/3 of our elderly population in Telangana has either bilateral or unilateral vision loss. This is a huge number that we need to address. We also looked at visual impairment in one of the project called as Hyderabad Ocular Morbidity and Elderly Study called as Home Study. Again, it was a longitudinal study. In this study, we found that 30% of them had distance vision impairment, about 51% of them had near vision impairment, and almost like out of every 10 people, 8 people had visual impairment, and most of it is avoidable. Cataract and refractive errors are a leading cause, and one important thing is PCO, posterior capsular opacification, is emerging as one of the important causes of vision loss in elderly populations. 90% of the vision loss is avoidable in homes for aged centers. Along with the vision loss, there is also several other comorbidities that are there. A quarter of them had depression, and a quarter of them had multidisability and also multimorbidity. The consequences of vision loss are very well known. Now we know that vision loss is also an important risk factor, cognitive impairment. Vision loss also predisposes people for early death or early mortality. Recently, we published a paper on Clever. I think Dr. Suvarna will be talking more about it, where we are trying to understand, by providing glasses, can we prevent a cognitive decline? And why should we talk about vision loss? Because vision loss is not only a health agenda, it is also a development agenda. Out of 17 sustainable development goals, 8 of them are directly or indirectly linked with eye health. And a lot of research is coming through that every intervention that we do for eye health drives the sustainable development goals. One of the important things is that almost everyone, almost 90% of the people, need to go to eye care provider at one point of time or other, and that is something that we can take advantage of. So last part of the epidemiological paradigm is how do we control the vision loss, and for that, universal eye health is one of the modality that is proposed. Universal eye health talks about providing preventive, promotive, curative, and rehabilitative care of sufficient quality, and also ensure that nobody is driven into poverty when this care is provided. That means every person should have equal access to quality eye care. And people should be the center of that care. Everything, whatever we do in eye care should be focused on the people. We call it as integrated people-centered care. And this integrated people-centered care is been endorsed by World Health Assembly 73rd and also 74th World Health Assembly has also given 2 indicators, effective refractive error coverage and effective cataract surgical coverage for 2030. And the recent Lancet Global Health Commission has clearly laid out the way forward to take care of vision loss. At LVPI, at LV Prasad Eye Institute in Hyderabad, where we developed a pyramidal model to provide universal eye care, where we have community-based health programs at the grassroots level, taking care of every 5,000 population, and then we have vision centers, secondary centers, and tertiary centers, covering a population of over 50 million population. One of the initiatives that was undertaken by the institute is called a Silver Sight Initiative, or eye care on call, where people can call and ask for eye examinations. We started on a pilot basis, and now we also have modified this into a complete program called as LVP at Home, where we provide eye care and we are reaching those who cannot reach us. It's a very simple process where people can make a phone call and then eye care team will go to their residences and provide care. We also have a teleconsultation for the complex cases. Teleophthalmology also is now available in our vision centers, where we are able to provide care for more complex conditions. We as eye health providers, I feel that eye health can be an entry point for holistic health care for the elderly, because almost every elderly need to visit eye health provider at one point of time or other. If we can provide that care and also doing something beyond our eye health, if we can triage for more complicated conditions and refer them to other service providers, we can provide holistic care for the elderly. Because good health means more years of life. Good health also means independence in activities of daily living, and also economic independence. And in conclusion, we have a large burden of vision loss in elderly. Uncorrected refractive errors is an important challenge. PCO is emerging as one of the important causes. We need a paradigm shift. Cataract is no longer a one-time intervention. We still have a lot of refractive errors to cover in this population. So good eye health is essential for healthy and happy living, and as India ages, we need more and more focused strategies so that we provide good health in sensitive years of life. And I take a bow to my gurus who are instrumented in shaping my career over the years, Dr. Rao, Jill Cave, and David Fredman, and I'll conclude my talk, and I'll take the questions at the end of my session. Thank you. I now invite Dr. Suvarna Alladi, Professor of Neurology, National Institute of Mental Health and Neurosciences, Bangalore, to deliver a talk on vision loss and cognition, something that I touched upon. Dr. Suvarna is a very well-known figure in neurology circles and in dementia circles. Her work on investigating the influence of life course experiences, bilingualism, education, social engagement on cognitive science is very well known. And whenever we talk about language and cognition, it is Dr. Suvarna's name that comes into forefront. Today she's going to talk to us about vision and cognition in elderly population. Dr. Suvarna.
So thank you very much, Dr. Srinivas. I'm really grateful to the Asia Pacific Academy of Ophthalmology Congress and the annual conference of the AIOS for inviting me. But especially, I'm grateful to Dr. Srinivas for putting together this wonderful symposium. I've really been enjoying all the talks. I cannot talk about primary health care and elderly health. I think this is the next presentation. So, Wait, I can do it here. That's fine, I can do it here. You're doing it? Okay. So, so I'm a clinical neurologist, and this is how my patients come to me. I think it's not moving. Right. Okay. So this is typically how my day is. Patients come to me saying, "Doctor, I've become forgetful. My mother is behaving oddly. I can't seem to find the right word. My husband is losing his way. My father has become very withdrawn. Or my mother is not able to recognize me." So what does cognitive neurology have to do with eye health in general? And with this particular symposium is what I'd like to make the connection in the next few minutes. And so when a patient comes like this to us, the first thing that we do is we try and find out which area of cognition is affected. Is it like, is it glaucoma, or is it lens, or is it retina and all of that? So we say, is it an attentional problem? Is it a problem with memory? Are they having problems expressing themselves? Is it a problem with spatial awareness or doing complex tasks? And once we make that kind of a clinical profile, we do some paper and pencil tasks which assess cognition in all these domains, and we do scans and other blood tests to make a diagnosis, and we are able to say, yes, this person has some cognitive decline, and if it's severe enough, this is dementia. It's a new disease in India. Even 30 years ago, this is a door-to-door survey of people in rural Kashmir, and patients with dementia were not found. But today we know that 1 in 12 people over the age of 60 years actually have cognitive impairment and dementia. And very topical to this particular session on older people, the number of people with dementia is rising because the people in old age in India is rapidly rising, and age, Dr. Srinivas mentioned, is a non-modifiable risk factor for dementia. You can see, while this person is getting older and is at risk of developing dementia, they are also at risk of developing several other diseases, and particularly here, eye diseases. And you can see both cognitive decline and visual impairment share some pathologies: neurodegeneration, vascular diseases, diabetes, metabolic disorders, toxins, malignancies. So you can see aging is associated with disorders that affect both vision and cognitive function. And Dr. Srinivas was talking about his home study, and a clear association has been found between people living in residential areas in Hyderabad between vision impairment and cognitive impairment. So there is a clear association. Even at the disease level, you can see people with dementia have a higher prevalence of age-related macular degeneration, cataracts, and other eye diseases. In fact, as cognition is declining, the retinal nerve fiber seems to be thinning down, so much so that it's being considered to be a potential biomarker in Alzheimer's disease dementia. So there is a clear association between the two. But is it just an association? There is more and more evidence that there is actually a relationship between these two conditions. It is not a chance association. There is a bidirectional relationship. For instance, from the area of cognition where I come from, cognitive decline can present as vision impairment, and cognitive decline increases the presence of vision impairment. Coming from the viewpoint of people who work with vision impairment increases cognitive load. Vision impairment accelerates the risk of cognitive decline and dementia, and therefore there seems to be a real bidirectional relationship between these two. What I'd like to do is describe this bidirectional relationships, firstly with some case scenarios. This was a 65-year-old lady in Hyderabad, this was more than 15 years back, who actually presented with visual disturbances for 3 years. She said she couldn't see very well. Her daughter said she couldn't see very well. She had problems placing the vessels on the stove and finding things in her clothes cupboard. She had wayfinding difficulty. And she went to many ophthalmologists. And she also underwent cataract extraction. You know, cataract is common among older people, but there was no improvement. It was only when she developed forgetfulness for 1 year she came to us. And when we showed her these fragmented pictures, she said, "Those black things, doctor, I don't get them." So clearly had a problem there. Her visual acuity was 6/18 by the old definition. It is still all right. She should not have so much problems in seeing. And then she had, you can see, she could not recognize the larger A's, that's simultagnosia. She couldn't recognize faces. She couldn't draw these pictures. So clear impairment visual perception and visual construction, higher cognitive visual processing. This is a PET scan you can see on your right. Clearly the parietal lobes do not have metabolism. They're all green, while the frontal lobes are all yellow and red. So the posterior part of her brain did not show metabolism. This is a condition called posterior cortical atrophy, and people with Alzheimer's disease, 5% of them come with just visual impairment for a long time. The first connection. Moving to the second connection. This is Zeba Bashiruddin, an inspirational figure. She was a professor of English literature in Osmania University in Hyderabad. She presented with 2 years history of difficulty in speaking, and for 6 months she had not spoken at all. So we diagnosed a condition called non-fluent aphasia in her. Her daughter noticed that she also had worsening of vision, a very alert caregiver. This is, again, I'm talking about 2006 and 7. Detected to have cataract. Now when somebody is not speaking and they're already having dementia, do you have to do something? Now it's evident that we do a cataract extraction. I called up my friend who's an ophthalmologist in Singapore actually, and I asked her, can we do a cataract extraction? And she said, yeah, in Singapore we have lots of old people, we are doing cataract extractions, they do well. So then we did both speech therapy and cataract extraction, and you can see the black painting, she was an artist, which she was doing. See how beautifully it has improved. Similarly, she started speaking again. When we told her the hare and tortoise story, when we said slow and steady, after 6 months, she gently said, wins the race. So you can see how a combination of cognitive therapy and improving vision actually changed her life. And so her, she really inspires us. And from then, it's just been, so clearly cognitive impairment worsens impact of vision. And when you have cognitive decline, they do not seek eye care, and this leads to a higher burden of untreated. We again heard beautifully from the previous talk about untreated visual refractive errors. So, and this really typifies that. Now moving on to the other way, vision and its impact on cognition. Clearly you need vision to perform your activities of daily living, and if you have impaired vision, it lays a cognitive load. If you can't see very well, you have to use more of your brain to make sense of things around you. And now what we know more and more is that when you have visual impairment in the elderly population, it really increases the risk of developing dementia. This is a meta-analysis. So older adults with vision impairment are 3 times more likely to experience severe cognitive decline. We've heard of its impact. We've heard of impact of visual impairment so far in the last 3 talks on mental health. But I'm bringing in cognitive decline. Is it the mediator? Is it one of the factors that actually produces depression? We talked about loneliness. Is it the factor that is accounting for some of the loneliness? We've talked about falls. I really must congratulate the people in public health, in ophthalmology, who have looked at falls and sarcopenia much before we neurologists have actually started looking at it as a public health entity. So there are several mechanisms of interaction, shared pathologies, reduced neural activity, and associated depression, physical inactivity, and social isolation relating the two. And this is the Lancet paper that we wrote last year. And in addition, and that 45% of all risk for dementia can be reduced, modified. And it's only last year that vision crept into this list. And 2% of dementia risk, we said, can be reduced by correcting vision. And this actually is the concept of cognitive reserve and neuroplasticity. Every man or woman or a person, if they desire, can become the sculptor of his own brain. This is Roman Cajal, a famous neuroanatomist, and we now know that there are many things you can do during life course that can improve reserve in the brain and resist effects of disease. And along with physical activity, we have done some research that if you speak 2 languages, you can actually protect yourself from developing dementia early. You can see now that correcting vision also shapes the brain. And this is the concept of cognitive reserve. So there is huge scope for intervention. It is meetings like this, and I wish we had a similar meeting. Dr. Srinivas, in our neurology meeting, we'll invite you there now. and all of you. And we have to have a collaborative approach where we assess vision and cognition together and improve outcomes together. And this brings me to the study I'm very privileged to be part of, CLEVER, Cognitive Level Enhancement through Vision Exams and Refraction that we are doing at NIMHANS with LV Prasad. Srinivas and Dr. Rohit are leading this with Dr. Nathan in Queen's University. So it's a single center, open label, parallel group, individually randomized control trial where we are testing the impact of correcting refractive error through free glasses on cognition by doing detailed cognitive assessment every year over 3 years in community dwelling elderly persons. And it is a massive, massive exercise that Dr. Srinivas has undertaken, and the amount of effort that's going into the villages, convincing people with extreme rigor, conducting eye tests, doing the cognitive examination. It's been a learning for me. So this is what we are looking forward to taking forward in the next few years and trying and understanding whether improving vision improves cognition and reduces the risk of cognitive decline. So you can see there are for interested people, students especially, there is a lot of research that can be done and needs to be done linking the two. What is the risk? What is the relationship between sensory deprivation, sensory impairment, and cognitive decline, whether it's hearing? And what are the innovative interventions like we are seeing in CLEVER, just providing glasses? Are there any other effective interventions that can be done that can improve cognitive outcomes? How do we improve our own cognitive resilience through? So this can be a window to understanding cognitive resilience. Most importantly, I think we will impact policy. The National Program for Prevention of Blindness has to work. We have to have a brain health policy, and we have to work together. And I quote again Dr. Srinivas. He says, he just told us eye health is the entry to holistic health. He has told me repeatedly that eye health is an entry to brain health. And I think that is something that we really need to look forward to in the future. So to conclude, we need integrated healthcare strategies to focus on both vision and cognitive health, which for improving quality of life of aging populations. So this is a large group of people that are working in the CLEVER study in LV Prasad and in Hyderabad and Nizams and in NIMHANS that really have brought all of this together. So thank you very much.
Thank you, Dr. Suvarna. That was a fantastic talk. Now we have the last talk of the day. Now I invite Dr. Yeni Lestari, ophthalmologist from Indonesia, to deliver the lecture, Primary Health Care and Elderly Eye Health.
No, I mean the slide. Okay. Thank you. Good morning, everyone. I'm Yeni Dwi Lestari, and I'm a community ophthalmologist from Jakarta, Indonesia. And today I would like to share about the primary health care and elderly eye health, especially what happened in Indonesia. So I have no conflict of interest to declare. As we know that the global aging trend and it's increasing everywhere and globally, as we see that there is a projection increasing the older or elderly population is keep increasing. Yeah, there are more than, and we know that there are more than 32 million people living with blindness that were aged over 50 years old. So usually we get the data from the RAP survey. It's a standardized survey methods that conducted in a lot of country, and finally we get the data globally, and almost 370 million people living with visual impairment. Yeah, it's also over 50 years old. So we know that age is related with the blindness and visual impairment. So in order to face this trend, the health services for elderly, including eye health, are critical to maintain the quality of life and reduce the burden of the healthcare system. Like Dr. Srinivas said that in older people, the vision or the visual impairment can cause not only the clinical or the clinical impact, but also the mentally health and also the economic impact. So WHO is already implemented the universal health coverage, and the universal health coverage will not reach without the universal eye health. And after the implementation of universal eye health, we have a world report on vision with the integrated people eye-centered approach that aim that everyone can get good quality access without the financial hardship. So with that program, we also know that the health for older people is also need to be included if we want to reach the universal health care. And although the universal health coverage has targeted the elderly population, but unfortunately in several countries like Indonesia, eye health is often overlooked in this program. So we know that the primary health care is critical foundation for universal health coverage. That's why the integration of eye health into the primary health care is very important. And to fully realize that the potential of universal health coverage, the eye care services must be explicitly integrated into national health plans, ensuring that older adults have access to comprehensive eye examination, treatment, and also the rehabilitation services. And we know there is also some approach for the older people. It calls ICOP, or Integrated Care for Older People. And the main target group is the older people with declines in intrinsic capacity and also functional ability that look the locomotor capacity, the vitality, visual capacity, and hearing capacity, and also the cognitive capacity and psychological capacity. And in one of the pillar is the visual impairment. The implementation handbook is stated that what can we do to screen the older people for the visual impairment. It's just a simple test visual acuity, assess and manage visual impairment and eye diseases such as cataract, because we know that more than 50% cause of the blindness is due to cataract, and cataract is a age-related eye disease. Detect and treat hypertension and diabetes, adapt home to prevent falls, and provide assistive device, such as glasses, desk, and mobile magnifier. And if we want to put this approach, the IPEC and ICOP into our daily health services in primary healthcare, it will be very comprehensive for this population. That's why the strengthening services for older adults through the integration of primary healthcare is very critical. Why we need to integrate? Because we know that eye health alone is not is often not a health priority program in a country. Yeah? Like in Indonesia, eye health is not a
health priority program like life-threatening diseases like diabetes or heart diseases. That's why the funding or the budget itself is not too big as the life-threatening diseases. That's why we need to integrate along with the more general, more beyond only eye health, but we need to integrate in the general health. Yeah. There's some approach that we need to integrate it into eye health into the general health services, and then we need to empower people and communities. And also we done the multi-sectoral policy and action, and these are the three main strategies for primary health care recommended by the WHO. And what kind of services that older people need, especially for the eye health? We found there is a scoping review in 2023, but this is conducted in the high-income countries, and they found that actually the type of services for eye health in the primary health care is the commonest one is refractive error correction, and it's in line up with the epidemiology that the refractive error is the most common disease seen in the primary care. And also the eye examination to detect cataract and also diabetic retinopathy, and also the low vision services. And that is the biggest type of, or the commonest types of services in primary healthcare. And they also assess what is the types of universal health coverage dimension, and the most common stated is or report is the equity and access. They said that the primary eye care in the primary health care is showing that the access and the equity can be reached. Yeah? So the patient can access more to the primary than to the secondary or tertiary one. How about in Indonesia? Older population projection 2010 to 2045, the older population is keep growing, yeah, and it's predicted to 20% of the population in 2045, and 44% is still actively working, but the data doesn't state how much is the income. Can it enough to support the morbidity or the treatment costs for the older people? And in another data said that the prevalence of blindness in Indonesia is reached to 3%, and it's quite big, and most of them caused by cataract and refractive error. So it's this blindness is avoidable. So if we can prevent, this blindness should not be happen. So Indonesia's program through primary health care, it's implementation policy related to integration of primary healthcare services. So we have a new program. It calls the primary healthcare service integration of primary healthcare services, and they have 5 clusters on it. The first cluster is the administrative management. The second one is the healthcare for mother and children. The third cluster is the health of adults and elderly. The fourth cluster is for chronic diseases, and the fifth cluster is for rehabilitative. So we're focusing on a life cycle or people-centered approach to ensure more comprehensive, responsive, and accessible healthcare services. And adult and elderly are included in cluster 3. The type of eye services is the first one is sorry. The first one is the visual acuity. basic visual acuity testing that conducted by the cadre, the trained cadre. They only used the finger counting method, and they were asked to refer the patient if the patient cannot count from 6-meter finger counting. And the second one is visual acuity and cataract detected. It's conducted by the GPs in the primary healthcare using the Snellen chart, and they can do the simple refractive surfaces and shadow test using the torch because they don't have a slit lamp. Cataract cases are referred if the visual acuity is below 618 and the patient agree for surgery. And then they can provide also the diabetic retinopathy screening, but it's not formally or routinely done. It's only in several primary healthcare that the GP is already trained. So, and the third one is the free health screening. This is a new program launched by the ministry, and they provide the free health screening, especially on your birthday. So when you have a birthday, there is a message from the application. It's Satu Sehat Mobile. Everyone get the account, and they were reminded they can have a free health screening in the primary healthcare, and it also include the eye check. So the challenge is to implement the services for the eye services for elderly people is it needs a multifaceted approach that integrates eye health into primary care system, promotes early detection, treatment, and reduce barrier to access. And we still find the cost-effective approach because we know that older people usually come with visual impairment and other morbidities. So they need to prioritize which one they want to be prevented or to be cured. And for the conclusion, the integration of eye care for the elderly in primary healthcare is a potential strategy to achieve the universal health coverage. And for developing country like Indonesia, the IPAC and ICOP approach strategies can be used in providing elderly eye health services. So that's all. Thank you. Happy to present in this occasion.
Thank you. Thanks, Yeni. Now I open the floor for questions.
Nice presentations. I only had a doubt. See, cognition also has other aspects other than our visual impairment, hearing impairment. Has there been any correlation between the hearing impairment and the visual impairment, and how much is our correction going to benefit the patient by and large?
Preeti, do you want to take that question? Or?
Sure. Okay, I think, that's really very interesting, as we know that both vision and hearing impairment are the modifiable risk factors, and as shown in the Lancet papers in the recent very publication, they have included both. So it will be really good to see, how the dual sensory impairment, particularly vision and hearing, what's their impact, in terms of association, is it just additive or does it go above and beyond? That is there any synergistic association? And also in terms of impact, some RCTs would be good to look into when we correct both vision and hearing, which are easily correctable, at least by the hearing aid, and vision we know can be, as shown here, cataract, refractive error are the major correctable causes. So it would be really good to see the impact of dual sensory impairment, and as per my recent knowledge, I think there is not much work done on dual sensory impact, its association with cognitive impairment. And it would be really good to see, and to be honest, we are really looking into a grant at the moment on writing RCT on dual sensory impairment and the impact on cognitive impairment, and we plan to submit it in upcoming 2 to 3 months.
Thanks, Preeti. I was expecting that. So I think we also looked at not cognition, but we looked at depression and dual sensory impairment. And in fact, if you see, the depression is more common among those people with hearing impairment when compared to visual impairment. among those people who have dual sensory impairment, the prevalence of depression goes as high as about 60%. So definitely there's a lot of association between these two, and these two are very important senses, and I'm sure they must be having more than additive effect, cognition and dual sensory impairment. So any other questions anyone has got? So if not, I have one question, Sahil. Again, you presented the intricacies of doing a longitudinal studies, and I can tell you, in low and middle countries, doing a longitudinal study is not easy. It's full of challenges. Typically, we publish methods paper, like we published a clever paper and then several papers published, but most of the times, these intricacies are never presented, but you presented it well. One question I had is, what is the time taken for entire assessment in your seats? Because we face the same problem of timing, and was it done in single session, or how did you overcome the tiredness and the response rate, consistent response rate across all the questionnaires in the study?
Thanks for the question. I think for seed study, what has happened is one,
Maybe Sahil, you want to go?
funding is always critical, and funding allows you to do a very unique thing, that you can stratify your resources for running the study in parallel at the same time, but still making sure that there is enough space. One, there is always that space constraint, and also the equipment constraint. So what happens in SEED is we have 2 sessions, morning and evening, and in every session, 3 to 4 patients are scheduled only, which is very unique. When I was in India, we used to see about 100 patients in our morning session in our OPDs, but for the epidemiological study, it's 3 patients that we see, 3 or 4. Usually the time taken is about 3 to 4 hours. The timing is such that after the consent is taken, we also have some time in between for refreshment breaks. So it's the design of the SEED study in a way that we have coordinators that talk to them like friends in their common language. There is enough space in between the test that the elderly patients, they can take a break. All the facilities are on the same floor, which means they don't have to go, once they have reached the same floor, they don't have to go to any other place in order to get any of the examinations done. We have the rooms which are very close by. We make sure that even the other amenities, say for example, the toilets, are also on the same floor as well. And what happens with this kind of a setup is, yes, one, the timing part, some things are on schedule, so the coordinators, they have like time charts, they know how much time to spend, but still all of them go through that drilled training, how to keep it conversational, yet follow a standardized protocol. And that only comes with a lot of experience. So 3 hours is the time it takes, 3.5, depending upon how difficult it can get for some of the elderly in case you have a very hard cataract. Then it can be extended a little bit to 4.5. But there is also that ability that in case a patient feels uneasy and they have to go back, they can be rescheduled on another day. And that feasibility is only allowed, again, just because of how we are able to kind of optimize the time, the equipment, and the resources at the same time. So that's how the SEED is structured.
Yeah, I think despite of three hours of questionnaire, and also you're able to get about 80% response rate, which is definitely a phenomenal achievement. Thank you, Sahil.
Sure.
Yeah, just a very quick addition to what Sahil has explained. So, yeah, SEED, yes, we spent, I was part of SEED as well, and 3 to 4 hours in testing these patients who are like around 50 years old. But we then started Pioneer study, which is even more elderly because they are all 60 and above, and the mean age is around 75. And Pioneer, because we have taken a step further, and they have not just undertaken the eye, but also the sensory impairment and other cognitive assessment and all those things. So Pioneer takes around 6 hours, which is really insane, right? So what we have done is we have splitted the sessions. So they come for the first visit, which is the clinical visit, and they do all the objective assessment. Of course, the primary focus is the eye, and some sensory assessment like hearing. We even do smell test because the focus is on sensory here. And then we scheduled a second visit for the participant to come and do the interview, the questionnaire, because questionnaire is also very important information in public health, right? because we believe that if they are fatigued, then it's kind of garbage in, garbage out, and we really do not want that. So they come fresh for the second visit next time and do the questionnaire, and some of the remaining tests from the clinical assessment, which at the time of like taking a fundus photo, we realize that the patient is fatigued and can't really get the very clear picture. They cannot cooperate for OCT, for example. So we bring these tests forward to the next visit and do that. And yes, as Sahil mentioned, we provide them refreshment, breaks in the middle. The coordinators are very familiar in terms of language, everything. So we do cater for all these in order to really get the good data and good response rate. And last but not least, there is another provision which we have is we go back to the participant house in case they are not able to come for their second visit to the clinic, because we closely monitor the loss to follow-up, and after investing so much time, like 4 hours in the first visit, we do not want the data to be lost at the interview session. So because interviews can be done at home, so we do send our coordinator or the research team to their house and do the interview, and some of the tests, for instance, TRAILS A and TRAILS B, which can be done easily at home, is another strategy which we follow in order to really get a comprehensive data collected as well as a good response rate.
Yeah, I'll just add one more point to that. So when we look at the response time, right, and we are measuring those 3 hours, we are actually ignoring that there are so many hours that go in before the study and after the study as well. So the before study part is the coordinators calling these people up, making sure that for the next 3-4 months, everything is well scheduled, well lined up, making sure the transport arrangements are in place. So we have ability that we can give or provide them taxis for coming in and also for going back. So those little logistics are also very, very important. And you know, the time that is taken for those activities often gets lost, but it's totally a teamwork effort. And the other part is once the data is collected, so much goes into making sure that the data is clean, making sure everything gets labeled. We have trained graders, so every image that is taken goes through multiple rounds of labeling, just to make sure that those data standards that we have for every image are absolutely perfect to the best of our abilities. And that's why we can do so much of AI work as well. Only once you have such robust collection, robust data storage, and robust data curation of the labels, that's when you can do much more, which is like planned beyond your original study purpose. So yeah, thank you so much.
Thank you for sharing the insights, Sahil. Dr. Suvarna, you gave a wonderful talk on vision and cognition. So almost like we and vision people and also cognition people, we do things in several similar ways. For example, the visual processing, as you call it, we call it as visual functioning, and you see that there's so much of similarities. And despite that, so many years we have been working in isolation, talks volumes about how the specialists work for years together without working together. I think now we are coming together to understand this vision and cognition, and thank you for that study. Now we are talking about vision and cognition, how they are very much intricately linked. So that's, any other questions from anybody? And we had Yeni talking about ICOPE tool. I'm not sure how many people in vision care or ophthalmology are aware of that tool. It is a fantastic tool. Many times as eye care providers, that happens even in my institute as well, many of the times as eye care providers, we are very much focused on eyes. We fail to see beyond eyes, and ICOPE is a simple tool which Yeni has alluded to, a very simple tool that can be used by anyone with limited training. We as ophthalmologists can take advantage of being the people who can triage using these and refer to the subspecialties where they can get more care. That way we'll be doing a greater benefit to our elderly people. With that note, I conclude the session. I request the speakers to come over here for a group photograph. Thank you all for your attention.